Kia ora koutou. Good morning, everyone. Now, I'm going to be talking about mental health today, and I understand this is a general health symposium. I have very little experience in general health or expertise in other areas of health. I'm quite lucky that I don't have much experience in other areas of health. I do visit a GP occasionally, but only for minor things. Now, mental health may not be an area that you know a lot about, and in fact, probably some of you are probably very fond of the refer button. But I'm going to share a view that many of you may not have been exposed to, and it's a view derived from using services and having a long career advocating for a better deal for people. Now, mental health is a bit different than other areas of health. In fact, I think it's very different. And I've always argued that it should be primarily a social service rather than a health service. And I believe that medicine, while it has quite a lot to offer in many other areas of health, has very limited things to offer in mental health. I wouldn't argue that it's got nothing to offer, but I think what it has to offer is very limited. But there may be parallels from this talk, especially if you work with people with ongoing conditions or people who are disadvantaged. Now I'm going to explore, I know I've got this topic, the power of the consumer voice, and but before I explore that, I'm going to explore the broader system, because it felt a bit like, someone had asked me to talk about the chandeliers in the ballroom of the cruise ship, when actually the cruise ship has gone aground. In fact, the mental health cruise ship, the one we're on at the moment, has been going for about 200 years, and I would argue that it's never really floated as a whole system. Now, a note about language. I use mental distress rather than the term mental illness. I don't use the word consumer. Instead, I use service user, person with lived experience, peer, or person with experience of mental distress. Now, I just want to issue a health warning. Some of you who've spent your lives looking through a medical lens may feel disturbed, you may feel dismissive, your eyes might roll to the ceiling, or you even may feel a little angry about what I say. I don't take any pleasure out of making people feel angry, but it's just a collateral damage, you might say, from my message. In fact, your anger is probably not as great as the anger I feel about the way things are. And I actually believe I'm not a politician or a government official, and the reason I'm not those things is because telling the truth, as I see it, is incredibly important to my well-being, even if there is a little bit of collateral damage. So first of all, before I get on to Xena the alien, I'm going to tell you a little bit about myself. Now, I used mental health services as a young woman for about 8 years. This experience was the most monumental struggle of my whole life. I've experienced family members who've died prematurely, I've had separations, I've had job traumas, I've had all sorts of the usual things that people have. And they all pale into nothing compared to the struggle I had as a young woman going through the mental health system. It was a massive existential crisis, and the way the system responded really did not help, it actually hindered. The first thing they did was they gave me a pessimistic prognosis. So at the age of 20, I was told that I would not have a career like I was hoping to have, that I might be able to eke out an existence of working part-time, but I would continue to have episodes for the rest of my life. Well, I haven't had an episode since I was in my late 20s, so they were wrong about that. And then another thing that got to me about the service that I used was that there was no interest in my subjective experience of my distress. They saw my symptoms, and they just wanted, I think they were kind of like frustrated surgeons. I mean, they just wanted to sort of take it out or excise it from me. Is that the right word? But they couldn't. I mean, they tried, but they were not interested in these massive experiences that I was having, these quite profound, terrifying, amazing, life-changing experiences. In those days, it was very much a pills and pillows service, and to a degree it still is. The pills and pillows didn't help me really at all, and there was really nothing available to enable my own recovery, to get on with my life. And unfortunately, my experience wasn't unusual, and in fact it was better than a lot of people's experiences of mental health services, because I had a gob, and I spoke back and I stood up for myself. And unfortunately, I still hear stories today of people who go through these systems and don't get the help they need, in fact get hindered. So, just a little bit about then. Since I had my last episode many years ago, I've done many things. Now, these days, I call myself a social entrepreneur. I mean, I don't know I've never known what to call myself, but social entrepreneur seemed to be a reasonable thing to call myself. So we are developing Swell, which is an online recovery toolkit in mental health and addiction that's peer-informed, whole of life, and integrated into service delivery. And we've also got Peer Zone, where we've developed workshops that are going in Australia, New Zealand, Canada, and soon to go into the US, one-to-one tools and a consultancy. And I've written a book called Madness Made Me. It's a memoir about my experiences. So if you want to know a bit more about me, you can buy it on Amazon or at Unity Books. Now, this is, I found this yesterday. I found this very funny. I hope you don't mind the F word there. But this is my life as an entrepreneur. And I thought, well, actually, that was rather like my life as a person with mental distress. But there's a huge difference. An entrepreneurial crisis is driven by a big mission. An existential crisis, like the ones I had when I was in the mental health system, locks you into complete loss of meaning and purpose. So, let's get on to Zena. Zena is from a planet called Aqualis. She is rational, she is compassionate, and she has lived experience and a commitment to social justice. Now, I do have a real Zena who's a blow-up alien, but I left her in Melbourne, so I'm sorry she's not here today. Zena's mission is to visit planet Earth to review their responses to mental distress and make recommendations based on our best in the universe responses on planet Aqualis. Zena comes down to planet Earth, and she talks to a whole lot of experts, she talks to people with lived experience, and she reads the literature, and she has a really thorough review of what's going on. And the first thing she asks is, what are humans like? The experts tell her that, look, they're very social, they're pretty intelligent, they can be incredibly innovative, they're very prone to cognitive bias. Of course, Zena's people don't have all this human baggage that we've got. So, they have a heightened response to threat often, which sometimes is a very good thing to have, but quite often isn't. And they have elaborate social hierarchies. Now, where do you think people with mental distress are on this hierarchy? That's a trick question, because actually they're here. So then she asks, what are the causes of mental distress? So the experts tell her, firstly, the people with lived experience, they tend to say, well, bad things happen to us. That's why we have mental distress. And, once they get into the mental health system and they're told they've had a chemical imbalance, they might add that to their reasons for getting mental distress, but most people say, I got mental distress because bad things happened to me. Now, the expert, that guy up there or that woman up there, that's just the generic expert that Zena talks to. They say there's a general consensus, although I don't know if there's a total consensus, but that genes do not explain much mental illness. And that in a study in 59 studies, 47% of people with psychosis had suffered sexual abuse. But with all this information coming on board, there is an increase that biological explanations since DSM-3 came out in 1980 and since Prozac was released in 1987, there's been a real drive among Big Pharma and the American Psychiatric Association to get those biological explanations to increasingly dominate professional and popular discourses. Now, Zena said, well, what are the sort of outcomes people with mental distress have on planet Earth? And what the people with mental distress said is, the outcomes we want are just the same as everyone else. We want work, we want a good income, a lot of us want partners and children, and we want a long, healthy life, same as everyone else. But what are the outcomes really like for people who use mental health services? 80% are unemployed, greater than any other disability group. In Australia, I don't know what the figures are here, they're probably similar, 85% are dependent on welfare benefits for their main income. Less of them have partners and children, and if they do have children, they often get taken off them. They die up to 25 years younger. They're 20 times more. Now, the deaths up to 25 years younger, that excludes suicide, okay? But they're still 20 times more likely to die by suicide. This is what the experts told Zena. Now, SZ stands for that nasty word schizophrenia, which some of us are trying to get rid of. For people with a diagnosis of schizophrenia, there was 2 WHO studies done that showed that if you have schizophrenia in a low-income country, you do better than high-income countries. Now, in low-income countries, there are less drugs and less services, and they were so surprised by the first study that they repeated it, and they got the same results. Now, there's a guy called Richard Warner, who's an anthropologist and a psychiatrist. Interesting combination. He wrote a book called Recovery from Schizophrenia. The longitudinal studies of people with a diagnosis of schizophrenia began in 1880, and he tracked them all through to the late 1990s. And he said there's been no real change since 1880, despite the pharmacological revolution. He said there were some fluctuations over that time, and higher recovery rates were associated with a better labour market. So they went up after World War II and in the 1920s. Then last week there was a report out from the College of Psychiatrists that said the cost of the burden, SMI stands for serious mental illness, not a term I use, and the burden of serious mental illness in New Zealand equals 5% of GDP. That includes use of health services, use of community services, family input, and lost productivity. So now, sometimes I look at those figures and I just want to weep. I do. I think we have a system that we spend all this money on this, and I'll come into this in a minute. So this is what the experts said about the outcomes for people with mental distress. So then, Zena said to the people with mental distress, well, what helped you? And this is what they told her. Now, when I was a child, I used to go on seesaws with my older brother, and he was heavier than me, and I always used to end up sort of at the other end, and I couldn't get down. So I was the lighter one. Now, what people say about the responses they have on offer is that hospitals, medication and coercion always come up as pretty light on helpfulness. The things that are really helpful to people, peer support, services that address trauma, self-management, practical assistance in getting housing, employment and education, and and equal opportunities. They're the things that people say really, really helped me in my recovery. Now, what people with mental distress say about us hospitals is they hate them. They hate them. And the people who work in them usually hate them too. Why do we have them? You know, but anyway, we're humans and we do things like this. And, you know, they've done surveys of people who go into psychiatric wards, and half of them come out feeling worse than when they went in. What's this? So Zena's started to feel slightly mad in the head. Medication. Now, you get very mixed views about medication. You get people who say, I hated it, it harmed me. You get people who say, oh, it's great stuff, and you get people who are very ambivalent. And of course, a lot of evidence coming through that the antipsychotics, the latest generation antipsychotics are actually life-shortening. So they can do quite a lot of harm. And coercion. So the difference between mental health and most other areas of health is that we have a Mental Health Act. Now, what do people say about going under the Mental Health Act? Well, you can imagine they tend not to like it. Some of them think, well, you know, it might have been all right for a short time, but a lot of people hate it. And a lot of the processes that are undertaken when people go under the Mental Health Act, like forced injection, seclusion, being locked in wards, are very, very traumatic for people. And they re-traumatise already traumatised people. So this is what, this was the consensus about what helped. Now, where does the money go? This is really interesting. So what we have is a system. Zena's been told, people have told Zena what helps them, and we have a system where most of the money goes into the stuff that they don't find necessarily too helpful. Some of them do, but they're very ambivalent about it at the best. And tiny amounts of money go into the things that people find really helpful. Now this is, Zena is starting to feel a bit, she's wondering what the hell's going on here. Now we're doing better in New Zealand in the mental health sector than most countries. We put about nearly 30% of our resources into the peer support. You know, well, actually, the NGOs don't do all this stuff either, but they try to. But 30% of our money goes into the NGO sector, who have a fighting chance of doing the things that people find useful, more of a fighting chance than the hospitals and the clinics. But in most similar countries, that's 5 to 10%. So we're doing better in New Zealand than other places. Now, the interesting thing, one really interesting thing that someone told Zena was that 45% more money goes into biological research and into schizophrenia than into psychosocial or environmental research. 45 times more, looking for the elusive genes that are going to be, that people have been looking for a long time and haven't quite got to yet, if they ever do. So, Zena is thinking, why on earth is it like this? Why have we created a system where the power of the voice of the people is not getting through to the people who provide the services? Well, there's no power in that voice, because we keep providing services that people don't find very helpful. Well, the experts say to Zena, mental health systems have dual conflicting purposes. One is control and the other is healing. Now, this has been a problem all along. And the people who with mental distress say, well, we think control wins most of the time. Zena then asks people, well, why does the control agenda win so much? Well, the experts say, well, the professions and the community, it's rife with stigma and discrimination. We've got the community that's saying, off our streets, we don't want these people. We've got the professionals who say, yes, we're the experts. We're full of earnest grandiosity, and we'll come in and we'll take these people off your hands, community, and we will and we will put them away and look after them or lock them up or whatever we do, treat them or whatever we do. And there's a quiet collusion going on, and which is really interesting because the experts they don't challenge this. They don't challenge this unsustainable consensus that experts can just, that the professions and the institutions can make the community safe. And they just hide away with their tail between their legs and manage risk like anything, instead of standing up to this consensus and questioning it. Now, does it work? Does the control agenda work? Well, now when it comes to harm to self or others, I don't know how these people work this out, but they say in order to prevent a homicide, you'd have to lock about 10,000 people up. And in order to prevent a suicide, you have to lock up, a couple of hundred or something like that. Because we're very bad at predicting. Even the experts are very bad at predicting. But we spend a huge amount of energy trying to stop the imminent harm to self or others. And we do that, the mental health system does that, because the community says if anything goes wrong, you're to blame, which I think is totally unreasonable a lot of the time, but that's the way it is. Now, when it comes to those poor long-term outcomes, what does the community say? No worries, we don't mind. So the health system, the mental health system, feels terribly accountable for these short-term issues that it can't really actually in reality deal with, because you can't really predict when people are going to do stuff that the community doesn't want them to do. But they're not accountable for long-term outcomes, and that's a real problem. Now, Zena says, how can this happen? Well, we have powerful vested interests and dysfunctional systems. And they're all sitting in this room. We're all part of this. We're all sitting in this room with powerful vested interests and dysfunctional systems. There's a lot outside this room as well. And some of those vested interests are the community, who are fearful and discriminatory and fairly ignorant about things, mad ex-murderers and so on. You have the medical establishment, who really, I think, feel at home in the hospital setting. I don't think they feel quite as at home in the community setting, but I'm sure some of them do. And then in the mental health area, we've got the kind of the coercive element, and then we've got big pharma, and we've got the drug companies, who have had a huge influence on the way mental health services are delivered in the last 30 years, particularly. So, and then Zena on her travels, there was a lot of talk about peer support in the mental health field, and she wanted to know more about that. Now, peer support is when a person with lived experience of a condition or a challenge provides services alongside someone else who has that experience. And there is a lot of peer support beginning to happen in mental health. The Rising to the Challenge mentions peer support quite a lot. Whether it's been translated as much as into the ground as much as that policy suggests is another question. But a lot of talk, it's the fastest growing occupation in mental health today. Now, she asked about the evidence. Well, the evidence, there's quite a lot of evidence for peer support. I mean, not much from New Zealand, but an awful lot from America. So people who use peer support services have reduced distress and use of health services. Improvements in practical outcomes like employment and housing, increased self-efficacy and self-management, better social support and quality of life, better ability to communicate with providers. There's no evidence that peer support does harm. Now, there's plenty of evidence that some of the traditional interventions in mental health do a lot of harm, and they have the same or better outcomes to traditional services. But guess what? Less than 5% of people with mental distress have access to peer support. 99% of them have access to medication, whether they want it or not. Now, Zena's saying WTF. Do you know what that means? Yeah, okay, good, because, she really cannot believe this. She's really sort of tearing her hair out. I'm not sure if she has any hair, but, it's all gone now, you see, so. And she thinks, this just doesn't make sense. It's absurd, it's ridiculous. So she goes and sees a guy she knows called John McKnight. I don't know if any of you heard of John McKnight. John McKnight is a professor of something in Illinois somewhere, and he has a lot to say about helping institutions and professionals. And his argument is, if you want to, can you all read that? Yeah. His argument really is that over the last couple of 100 years, we've built up all these professions. We've created these institutions as part of the kind of, the industrial development, I guess. And they've really disabled individuals and communities. Now, while they've done some good things, there's been some fallout from this. And for people who are having difficulty in life, the institutions and the professions have actually taken on a large role in their lives. And in fact, there was a wonderful saying by a person with mental distress that I came across quite a while ago. And she said, "Everyone in my life is paid to be there." So we've wrapped people around, we've wrapped walls around them from their communities, whether they're visible or invisible walls, and we've dominated their lives with expensive professionals and disabled those people and their communities at the same time. So that kind of made sense to Zena. Now, Zena makes a conclusion. Now remember, Zena's highly rational, she's highly compassionate, she's got a very well developed sense of social justice, and she doesn't have the sort of baggage that us humans have. So she says, stigma and discrimination skew everything. And it's not like it's just something that happens in the community, it's happening in the health system. It happened when I got a pessimistic prognosis from the psychiatrist. It happened when people didn't understand that actually my experiences meant something to me. They weren't just things that had to be cut out. It happens when communities say, we're worried about axe murderers on our street. It happens in the process of diagnosis, and it happens inside the souls of people who serve people with mental distress. It happens everywhere. The second conclusion she came to is that mental health services routinely do harm. Now, mental health services can do good. But that doesn't take away from the fact that in the whole history of mental health, and we're not just talking historically, we're talking today, mental health services routinely do harm. Now, they do harm by telling people this is your life for the rest of your life, by prescribing drugs that are likely to be life-shortening, sometimes without consent. They do harm by re-traumatising people when they go into the hospital system, by forcibly injecting people, putting them into seclusion, and so on. They do harm by not offering the things that people really want, or not offering them in a way, not offering them to the degree that people can actually, that everyone gets access to them. Sort of like peer support. Less than 5% have access to it. So they do routinely do harm. It's not because of mistakes or incompetence. It's built into the very fabric of the way things are done. Now, the third conclusion she came to was there is no sense of urgency for change. And this is very sad. This is very, very sad. And that's due to vested interests and community ignorance, tolerance for psychiatric harm and poor outcomes, tolerance for those poor long-term outcomes, and systems that suppress innovation. They were the three things she came up with. How, 5 minutes? Good, okay. So what did Zena recommend? Well, the first thing she recommends, and this could be something that you could take over into the whole health sector, build peer leadership at all levels. That is the leadership of people who have lived experience of the particular condition. Developing an equal threshold for non-consent in health and justice. Now, at the moment, we have a Mental Health Act that lowers the threshold for compulsory or treatment without consent. For instance, in health, you know, if I'm a Jehovah's Witness and I say I don't want a blood transfusion, they say, yep, okay, we can't force you to do that. But in mental health, I can be forced to take treatment on the basis that I'm a harm to myself. Also in mental health, the Mental Health Act enables people to lose their freedom before they've even committed a crime. Now, you can't do that in the criminal justice system. So Zena's saying, get rid of those mental health acts and create an equal threshold with other citizens and other health consumers. De-invest in hospitals and professionally led services. Now, it's not to say that the professions don't have a role, they do. But you see, one of the problems with these, when you've got finite resources, as this government keeps telling us we have, that, then you cannot change a system just by adding on bits. You have to take something away. Because the add-ons are just precarious clip-ons if you don't actually fundamentally change the core service delivery as it is now. So de-invest in hospitals, and we did close down our hospitals, our big hospitals in New Zealand. That was a great thing, but we don't need all these beds in acute wards. Someone will shoot me for saying that, but we don't. There are places in the world where there are virtually no acute beds in hospitals. They're all dealt with in people's homes and in community places. Reinvest in community supports and opportunities, the kinds of things that people say are helpful. Publicly acknowledge psychiatric harm. Oh, we had an opportunity to do this in New Zealand 10 years ago, and the Ministry of Health and Crown Law blew it because they were worried about liability. There was a confidential forum, they called it a confidential forum. I forget the rest of the name of it, but people went and talked about their traumatic experience in these systems. And there really has to come a time when psychiatry, that's not to say, look, psychiatry's done good. That, it's not to say it's all harmful, but psychiatry has done, if you know anything about the history of psychiatry, it's eye-watering what psychiatrists have done, and it's eye-watering what psychiatry is doing still now. It's pretty bad stuff, some of it. So we need to publicly acknowledge it, because then we can move on. And we're not expecting people to be prosecuted, or this is about a collective acknowledgement. It's not about isolating individuals, because I don't believe in that. Because I think people come into services, they try and do their best, they've got limited mindsets, limited tools, and they're working in systems that don't help them. So, run ongoing anti-discrimination and social inclusion programs. Now, we are doing that in New Zealand. I think we could be doing a lot better at that, but that's pretty important. And then prevent early life trauma and deprivation. And I think there are some attempts at doing that at the moment. It's saying, let's get in early in people's lives before the damage is done, that will make their chances of being a user of mental health services down the track even greater. So that is what Zena recommends, and as I said, Zena will be talking about peer leadership at all levels in the panel.